webinar. And before starting this and introduction of the worthy speaker, I will request Professor Rashid to recite the Holy Quran. Professor Rashid
Right, sir. Right, sir. أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم الذين آمنوا وتطمئن قلوبهم بذكر الله الذين آمنوا وتطمئن قلوبهم بذكر الله ألا بذكر الله تطمئن القلوب الذين آمنوا وعملوا الصالحات طوبى لهم وحسن مآب. तर्जुमा ये सूरह राद है, 13वीं सूरत है। इसकी ये आयत नंबर 28 और 29 है, जिसमें दिलों के इत्मीनान और ज़ाहिर है इस हवाले से ब्लड प्रेशर और दिल की बीमारियां, उसका जिक्र है कि ये दिलों का इत्मीनान सिर्फ अल्लाह ताला के जिक्र से है। इसका जो तर्जुमे का मफहूम है वो मैं बता देता हूँ। ये वो लोग हैं जो ईमान लाए हैं और जिनके दिल अल्लाह के जिक्र से इत्मीनान हासिल करते हैं। याद रखो कि सिर्फ अल्लाह का जिक्र ही वो चीज़ है जिससे दिलों को इत्मीनान नसीब होता है। गर्ज जो लोग ईमान लाए हैं और जिन्होंने नेक अमल किए हैं, उनके हिस्से में खुशहाली भी है और बेहतरीन अंजाम भी। सदक़ल्लाहु अज़ीम।
Thank you, Professor Rashid. Today's webinar, it is the 59th webinar of the PMA. We started, you all know, from the last 2 years, we're running this webinar. In the beginning, we started on the COVID, but then we also gave the presentation webinar on different other infectious diseases and very important diseases. We know the most highest cause of the death in the world, not only in the Pakistan, in the world, is the heart attack. And today's this webinar is in the collaboration of Pakistan Physiological Society, Pakistan Azad Jammu Kashmir Medical College, Muzaffarabad, Women Medical College, our worthy sister, Professor Salma Kundi, and Pakistan Association of Pathologists. Thank you very much, madam. You always encourage me. You encouraged us all in starting this program. And today's speaker is Professor Major General Aslam. I know him from the last 20 years. Professor General Aslam was the Vice Chancellor of the UHS. Professor General Aslam is the only person who made so many changes in the UHS that we all recall that at the end of the day of the exam, on the next day was the result. So this is services that will be recorded in the history. General Aslam is a PhD. I am very thankful, General Aslam. He helped me when I was in KE in starting the PhD program. Sir, thank you very much. You are teachers of the teachers. और मैं आपका तारुफ नहीं करा सकता because I am just your pupil, just a very small before you. Thank you so much, sir. Over to you, Professor General Aslam Saab.
Thank you very much. Thank you very much, Professor Mulazim Hussain Bukhari and Professor Salma Kundi, and the participants to take time and to give me an opportunity to talk to this august gathering and the 59th webinar of Pakistan Medical Association with collaboration of PPS and Pakistan Association of Pathologists and South Asian Association of Physiologists, and patronage by Pakistan Medical Association. In the name of Allah, the most gracious, the most merciful. Now, today's topic is homeostasis, which means regulation or control of blood pressure and pathophysiopharmacology of hypertension. So this will be an overview, a brief overview, how blood pressure is maintained and what goes wrong when its blood pressure shoots up, and what is the therapeutics and what is the principle of the therapeutics behind the treatment. Now, in these 30 minutes to 40 minutes time, the learning outcomes of these 40 minutes spending is to understand the mechanisms of regulation of arterial blood pressure. Very simple. But the second component is to overview underpinning pathophysiopharmacological principle of hypertension. So with these learning objectives, let us start from the very beginning. That is, what is blood pressure? We all know that pressure of blood in the circulatory system. For a common man, it is a blood pressure of blood in the circulatory system. But slightly more, pressure of the circulating blood against the walls of the blood vessels. Most of this pressure results from the pumping of the heart. So that means left ventricular musculature or healthier musculature of the left ventricle determines the blood pressure. And then there are various theories and put forward what could be the normal blood pressure. But according to the 6th and 7th report of the Joint National Committee of Prevention, Detection and Treatment of High Blood Pressure in the USA, they agreed with this simple chart. But this is for the adults. This is for the adults, not in the neonates, not in the very, very old age. Now, that is, the normal blood pressure should be considered when systolic blood pressure is up to 120 millimeter of mercury and diastolic up to 80 millimeter of mercury. So then the stage comes as pre-hypertension, as we call pre-diabetics, so pre-hypertension. So pre-hypertension is when systolic blood pressure ranges between 120 to 140, right? And diastolic blood pressure ranges between 80 to 90 millimeter of mercury. Then comes the stage 1 hypertension, when systolic blood pressure ranges between 140 to 160, and then the diastolic blood pressure goes to 90 to 100. And then is the stage 2 hypertension, when systolic blood pressure is equal or once equal to 160 or more. So 160 or more is the stage 2 hypertension. And diastolic blood pressure is equal or more than 100 millimeter of mercury. And then comes stage 3 hypertension, when systolic blood pressure is 180 or above, and diastolic blood pressure is 110 or above millimeter of mercury. So this is the general standardization of the normal range of physiology and of various phases of hypertension. Then just to recall your knowledge, our knowledge, which we learned in the undergraduate curriculum, what are the principles which regulate arterial blood pressure, or which are the determinants of arterial blood pressure. Very simple, just in one slide overview. Arterial pressure is the product of cardiac output times or multiplied by total peripheral resistance. And please mind, main site of cardiac output is the ventricles, especially the left ventricle. And TPR is the product of the vasculature, blood vessels. So that is why it is called as cardiovascular. Cardiac output is the product of stroke volume times or multiplied by heart rate. And stroke volume equals and diastolic volume minus and systolic volume. So the main product of stroke volume is the ventricular contraction, especially the left ventricle. And main source of TPR is the arteriole, that is constriction or dilation of the arteriole. So main product of TPR, on which it depends upon, is the vascular structure and the vascular function. Constriction of arteriole will raise the blood pressure, especially diastolic, and relaxation or dilatation of the arterioles, they will cause fall in total peripheral resistance, thence diastolic blood pressure. And then what is pulse pressure? Difference between systolic blood pressure and diastolic blood pressure is called as pulse pressure. But main reliable guide is the mean arterial pressure, MAP. How can we work out mean arterial pressure? So that is diastolic blood pressure plus 1/3 of the pulse pressure. Or we can work it out systolic blood pressure plus double of the diastolic blood pressure divided by 3. So this is relatively much more constant, and the normal range of mean arterial pressure ranges between 65 to 110 millimeter of mercury. So this is the basic concept. These are the primary determinants of arterial blood pressure. And mean arterial pressure is a guide. So then the question arises, potency of arterial blood pressure, control of mechanism at different intervals. Now, which mechanism will come into an action for regulation of blood pressure and after how much of time? So within seconds, within 30 seconds, as you can see in this diagram, within 30 seconds, first response comes from baroreceptors, chemoreceptors, and from CNS ischemic response. Within 30 seconds, if there is fluctuation of blood pressure, so baroreceptor reflexes, chemoreceptor reflexes, and CNS ischemic response comes into an action to regulate. And then within the next 30 minutes, now stress relaxation of the blood vessels, capillary fluid shift, and the renal blood volume pressure control takes over the charge. And then within hours, and then within days, that is renin, angiotensin, aldosterone mechanism, and renal blood volume pressure control appears. Now we will elaborate this time after sudden change in the blood pressure. Now look at here, short-term regulation of blood pressure. So this slide depicts the rapidly acting control of mechanism for the blood pressure occurring within minutes to seconds. That is, if blood pressure shoots up or falls down, so which components? So baroreceptor reflex. So they will be in action within minutes, second to minutes, when blood pressure fluctuates between 60 to 100 millimeter of mercury. What do? They change the peripheral resistance, they change the heart rate, they change the stroke volume in response to changes in blood pressure. But if blood pressure falls further, that is between 40 to 60 millimeter of mercury, so then comes the role of the chemoreceptor reflexes. And these are very sensitive to lack of oxygen, and then is carbon dioxide and excess, and then is a low pH or say acidity of the blood. And then when blood pressure falls below 40 millimeter of mercury, say for example, hypovolemic shock, sudden large hemorrhage, so what we'll do, then the immediate response will be of the CNS ischemic response. Now it results from severe decrease of the blood flow to the brain. So one is the time consideration, the other is fluctuation between the systolic blood pressure, which may stimulate either baroreceptor reflex or chemoreceptor or CNS or all at one time within seconds to minutes. Let us see CNS ischemic response. When there is severe decreased blood flow to the brain because of sudden fall of the blood pressure below 40 millimeter of mercury, maybe due to sudden large hemorrhage, it leads to cerebral hypoxia. which may lead to the stimulation of the vasomotor center, which is located in medulla oblongata of the brain and causes powerful and intense vasoconstriction. There is increased sympathetic discharge. That means noradrenaline or norepinephrine is released in the plasma. What will this norepinephrine do? It will constrict all the arterioles, and the main arteries, and that will lead to increase in the blood flow and increase in the blood pressure. And then is the baroreceptor reflex. How do they control arterial blood pressure? We all know that baroreceptor transducers are sensors. They are located in the carotid sinus and aortic arch. And they're very sensitive to sudden fall in blood pressure, especially in response to hypovolemia. So if there's sudden large hemorrhage, hypovolemia occurs, so carotid sinus and aortic arch baroreceptors through the 9th and the 10th cranial nerve, they will go to the cardio-regulatory center in the medulla oblongata and sympathetic efferent, and they will stimulate the SA node, the myocardium, and they will secrete epinephrine, catecholamines to bring about the further actions. So baroreceptor reflexes, they are very much sensitive to sudden fall in the blood pressure due to hypovolemia or sudden large hemorrhage. Then how do chemoreceptor reflexes, they control arterial blood pressure? We know it by our background knowledge that chemoreceptor transducers are sensor cells are located in the aortic and the carotid bodies, aortic and carotid bodies. These aortic and carotid bodies contain chemoreceptor cells or transducers that respond when the blood flow decreases. And then through the glossopharyngeal nerve and through the vagus nerve, they try to control the blood pressure. And then is the famous system. Now, when we say intermediate regulation of blood pressure, so that is renin-angiotensin system. But when we say renin-angiotensin aldosterone system, so that means long-term of regulation of blood pressure. So what do we mean by renin-angiotensin or renin-angiotensin aldosterone mechanism to control the blood pressure? Please remember, there are 4 potent stimuli. There are 4 potent stimuli secretion of angiotensinogen, there are 4 potent stimuli secretion of a protein hormone from the juxtaglomerular cells of the kidney called as renin. Which are those? That is hypotension, especially of hypovolemic in origin, hypovolemia, hyponatremia, and hyperkalemia. So these are the 4 potent stimuli, so they secrete renin from the juxtaglomerular cells of the kidney. And then these 4 stimuli, they stimulate the hepatic cell to cause a protein substance called as angiotensinogen. So renin affects on its substrate angiotensinogen in the plasma and converts it into angiotensin 1. Angiotensin 1, so far it is said to be biologically inert or inactive. Angiotensin 1 is converted to its form, that is angiotensin 2, with the help of enzyme called as ACE enzyme or angiotensin converting enzyme. Now this angiotensin converting enzyme mainly secreted from the lungs, but it is also secreted from the kidney, from the skin, and from the other tissues, but mainly from the lungs. So ACE enzyme converts non-active angiotensin 1 into active angiotensin 2. This is the principle when we use ACE inhibitors as an antihypertensive drug. So basically we are trying that angiotensin 1 should be prevented from their conversion to angiotensin 2. So the major effect of angiotensin 2 is on the blood vessels. Which blood vessels? Especially the arteriole. They constrict the arteriole, and then total peripheral resistance is increased. So that leads to rise of diastolic blood pressure. And then angiotensin 2 has got other effects on the adrenal cortex, like on the outermost layer, zona glomerulosa layer of the adrenal cortex, to cause secretion of a steroid hormone called as aldosterone. Aldosterone, through the general circulation, affects the kidney. What does it do with the kidney? It causes sodium potassium, sodium chloride, sodium ammonium countertransport or exchange system. So what is the result? That sodium, chloride, bicarbonate, and water is conserved or retained in the plasma, in the ECF, at the expense of potassium and ammonium. So potassium is excreted and sodium, chloride, bicarbonate, and water is retained in the plasma. That leads to restoration of the normal, plasma volume, leading to rise of the blood pressure to bring it back to normal. So that means renin-angiotensin is intermediate. Renin-angiotensin aldosterone mechanism is long-term regulation of blood pressure. These are some of the factors which may stimulate or which may inhibit secretion of renin from the juxtaglomerular cells of the kidney located in the afferent arteriole of the kidney when it comes in contact with the cells of the distal convoluted tubule of the nephron. And then look at here. Then this was about the renin-angiotensin aldosterone system. So then there are certain vasoconstrictor and vasodilator substances which may increase or decrease the total peripheral resistance. Like, so this red circle is the circumference of one of the arteriole. Those factors which constrict these arterioles leading to rise of diastolic blood pressure is rise of CO2, fall in the temperature, and there is a norepinephrine, high concentration of adrenaline, angiotensin 2, and certain other neurotransmitters, endothelin, serotonin, prostaglandin, and reactive oxygen species. And those factors which dilate the arteriole leading to fall in diastolic blood pressure is fall in oxygen, rise of nitric oxide, temperature, potassium, hydrogen sulfide, and some other prostaglandin and some of the neurotransmitters. That means the vasodilator and vasoconstrictor substances change the diameter of the arteriole, leading to constriction or dilation, leading to rise or fall in the diastolic blood pressure through total peripheral resistance. And then look at here. Now we are coming to the second part. Gradually, we are tapering to the second part, that is pathophysiopharmacological, pharmacological underpinning principles of hypertension. So we are gradually diverting from basic to the applied medicine. So there are 3 angiotensins so far which have been known. The 4th angiotensin is in the research papers, it is emerging, but not had been made part of the text yet. Angiotensin 1 is inactive, as we have narrated earlier. But angiotensin 2, the major effect of angiotensin 2 is the constriction of the arteriole. And the other effect of angiotensin 2, is secretion of aldosterone, secretion of noradrenaline, secretion of vasopressin or ADH, and secretion of ACTH. Whereas angiotensin 3, the major effect of angiotensin 3 is on adrenal cortex to cause secretion of aldosterone. But besides this, it also causes suractivity, that is, presses the blood vessels to constrict the arteriole. Now with this, there have been discovery of angiotensin 2 receptors. The question arises, where are the angiotensin 2 receptors located in the body? Angiotensin 2 receptors are further subdivided into angiotensin 1, 81, and 82 type of angiotensin II receptors. 81A receptors are mainly located on the blood vessel wall. Like, so that means that angiotensin II mainly affects 81A type of receptors located on the blood vessel wall. 81B type of angiotensin II receptors are mainly located in the adrenal cortex. So that means aldosterone mainly affects through angiotensin AT1B type of receptors. Like, and then it's 82 type of receptors, they have been found in neonates and in the fetus. When they get discovered, that will mean that we are trying to learn the blood pressure changes, congenital or by some anomaly, like through in the fetus and in the neonate in the coming decades, right? And with the discovery of angiotensin II receptors, so this is a beautiful slide to be remembered by all the physicians and by the basic scientists and by the pathologists, which are paraclinical sciences groups. Like that is when we inhibit a drug for renin secretion or action. So that means this is the made easy, this is the made easy slide to know the locus of action of antihypertensive drugs, which are widely used these days. Like when we want to inhibit the prostaglandin synthesis, control the blood pressure, we use the drug indomethacin. We must know why are we using indomethacin? When our objectivity is to inhibit synthesis of prostaglandins to control the blood pressure, then we should prescribe indomethacin. When we intend to block the effect mainly produced by epinephrine, adrenaline, we use beta blocker drugs. Beta adrenergic blocker drug, like very widely used propranolol, then trade name is Indirol. And we wish to use, when we wish to block the effects mainly induced by norepinephrine, we use alpha adrenergic blocker drug, for example, phentolamine. But when we want to block the action of renin, right, on angiotensinogen, so that means we are trying to block conversion of renin to angiotensin 1. Then we use these group of antihypertensive drug, that is pepsatin and enalacarin. And when we want to block conversion of angiotensin 1 to angiotensin 2, we use angiotensin converting enzyme inhibitors, and many of us, even in this group, might be on a group of drug on captopril. So captopril is ACE inhibitor, and allopril is ACE inhibitors. What is ACE inhibitor? Blocking the conversion of angiotensin 1 to angiotensin 2. But these are the drugs which have changed the venue of antihypertensive treatment, and the pharmaceutical company have made billions of dollars trade all over the world. So 81, 82 type, as we have studied earlier in the previous slide, 81 and 82 type of angiotensin II receptor blockers. And widely used drug is serelasin. Serelasin is angiotensin II selective blocker of 81 and 82 type of receptors. And then when we want to block the effect of angiotensin T1 of angiotensin selective blocker, we use losartan. This easy day, which is widely used, is in fact losartan. What is it? It is 81 angiotensin 2 adrenergic selective receptor blocker drug. So at least this much of knowledge, every clinician and a basic scientist must know that why are we using this drug? What effect which we want to be achieved to control the blood pressure. And then look at here, and then calcium channel blockers are used as well to control the blood pressure. So there are three main types of calcium channel blockers. That is dihydropyridine, phenylethylamine, and benzothiamine. And dihydropyridine is divided into first generation, like nifedipine, of second generation, which is isradipine, nicardipine, and feldopine. And the third generation is amlodipine. And one of my student of PhD also worked on amlodipine, but that was amlodipine effect on the cell culture and the reproductive endocrinology. And then is phenylcalamine, now verapamil. So verapamil is used, it belongs to a group of drug of phenylalkylamine, which is a calcium channel blocker. And then is benzothiazine, like diltiazem, very widely used antihypertensive drug. Like, so what are the effects of calcium channel blocker? Now cardiovascular. Effect on the cardio is decrease contractility of the myocardium, to decrease the heart rate from the pacemaker, decrease the conduction velocity, that is the conduction of the impulse through the conductive tissues of the heart. And on the vascular effect, smooth muscle relaxation. Relaxation of the smooth muscle of the large arteries and of the arteriole. So this is the role and the major overview of the classification and nomenclature of calcium channel blockers, very widely used to control the blood pressure. And this is my probably the second last slide, which means what I have said so far. Like, so this is a summary what I have said so far, summary. Like blood pressure regulation and its pathology. So physiology and pathology of the blood pressure, a composite figure. At least this much of picture must be kept in mind by all the medicos, like all the medicos who are involved in basic or in clinical sciences. So first of all is the brain. First of all is the brain, sympathetic action, sympathetic activity, and the mechanism of thirst. So that is one of the factors. And then is the pituitary gland, secretion of angiotensin, ADH, antidiuretic hormone, as vasopressin. So vasopressin in more than physiological amount causes vasopressor effect. Like vasopressor effect through V2 type of receptors located in the later part of the distal convoluted tubule, and collecting duct, mainly on the collecting duct. And then is on the heart. What do they do with the heart? Inotropic effect, which means increase in force of contraction of the myocardium, of the left ventricle. Chronotropic effect, increase in rate of the heart, which means through the pacemaker, that is SA node, or cardiac hypertrophy. And then fourthly is the vasculature, the blood vessels, large arteries, and especially the arteriole. Arteriole is the main site of total peripheral resistance. Arteriole are mainly responsible for regulation of diastolic blood pressure. So that is vasoconstriction. We have studied vasoconstrictor and vasodilator substances. Or if there is a vascular growth, like if there is inflammation of the vasculature, if there is aggregation of the platelets, as occurs in thromboembolic phenomena. And then is the adrenal gland, that is the adrenal cortex, especially the outer layer of the adrenal cortex, zona glomerulosa layer of the adrenal cortex, which is devoid of ACTH receptors. For it, there are 4 potent stimuli: hypovolemia, hypernatremia, hyperkalemia, hypotension, and fall in blood pressure. And then is the kidney. What is done by the kidney? Water retention. Now, what is done by the adrenal cortex? Aldosterone secretion. What is done by the renal tubule? Sodium reabsorption. What is done by the kidney? Efferent arteriolar constriction. And what is done by the adrenal medulla, that is secretion of catecholamines, especially epinephrine. So that means underpinning principle of regulation of blood pressure, underpinning principle of the pathophysiological principle lies either on the brain or in the pituitary or in the heart or in the vasculature or in the kidney to regulate the blood pressure. So this will give us answer which tissues, which organs in the body play pivotal role in control or regulation of the blood pressure. So this is a summary of what we have said, except the therapeutics. Therapeutics, main drugs we have talked about. And this is the last slide, probably the last slide, that is the take-home message is take care of your brain. Musbat soch, positive thinking, forgiveness, like maafi mangte raho aur maafi dete raho. B, like parvar mat bano. First is in the brain. Don't secrete unnecessarily your adrenaline. And then is your heart. Take care of the cardiac and the vasculature. And then is take care of your kidneys. To regulate blood pressure, take care of your brain, take care of your heart and the blood vessels, and take care of your kidney. I will conclude my talk with the prayer, holy prayer, which has been offered by Professor Rashid Mahmood, कि दिलों का इत्मीनान, like अल्लाह के जिक्र से होता है, so दिमाग, ज़हन को अच्छा रखें, ताकि हमारे गुर्दे भी महफूज रखें और blood pressure भी control रहे. With these words, I thank you very much indeed for your patient listening. Thank you.
Thank you very much, sir. Thank you very much. Before I start question and answer, I will request Professor Humayun, as I'm looking, Professor Humayun is there. Can you add few comments, Professor Humayun?
Aslam alaikum to everybody.
Sir.
Thank you very much for such a nice presentation, Professor
Thank you.
Aslam.
Thank you. My pleasure.
It was really informative, and I am sorry that I was a bit late. Nevertheless, I got some many things, and what I will conclude that take-home message, that while you assess a patient with essential hypertension, two things must be evaluated by the clinician, or as a physiologist even we should also. One is what is his graph of intake of the sodium per day? Has it shifted to the right? If it is shifted to the right, then it is very difficult to manage the essential hypertension. Second thing is to regulate or to look at the diastolic blood pressure and the total peripheral resistance. If it is not responding to the alpha channel blockers or any other drug like 81 receptor blockers, there should be dilatation and there should be decrease in the TPR. So yeah, these drugs are given over here, losartan and captopril, but now we have other drugs like what is calcium channel blocker present in Norwest. I don't know the remember at the moment it's formula name, and the other is the valsartan, which is 81 receptor blocker. So I think it is verapamil, so this is I think amlodipine. Yeah. So they will decrease they should decrease the TPR and they should decrease the diastolic blood pressure. So this is very important in essential hypertension to have a look on the diastolic blood pressure and DPR. Thank you very much, Professor. I'm really thankful to you for your nice presentation. And
thank you very much. My pleasure.
Thank you.
And it is also very, very. I'm really very, very happy to see you even on screen after a very long time.
Even we are also happy to see you, sir, in the active form, sir.
Oh, thank you very much.
Every week. Yes, sir.
Thank you very much. Thank you very much.
Before Professor Munir, I gave you the chance for asking the question because it is today is the show of physiology peoples. I will request Professor Salma Kundi. Madam Salma Kundi, can you add? I do not think there is anything deficiency, but
Yeah,
as a physiologist, can you add?
Actually, there is. I need not add anything because whatever General Saab
Yes.
said, वो क्या कहते
Yes.
हैं दरिया को कूजे में बंद कर दिया है. I'm so really grateful for such a
शुक्र है
nice
आपने ये नहीं कहा दरिया को फोसे में बंद कर दिया है.
कूजे में जी. It was a great talk, General Saab.
Thank you very
And
much. My
it
pleasure.
was
My
a
honor.
pleasure listening to you. मैं सिर्फ ये कहना चाह रही थी कि थोड़ा सा हमें मुलाजिम साहब जरा शुगर के ऊपर करना चाहिए डायबिटीज, क्योंकि जनरल साहब ने जो आखिर में कहा कि हमें अपने दिमाग का, अपने गुर्दों का, सब चीजों का ख्याल रखना चाहिए. जितने ऑर्गन्स का इन्होंने नाम लिया, शुगर उन सबको चट कर जाती है. सो लेट्स नाउ कंसंट्रेट ऑन डायबिटीज के दिमाग के जरिए तो हम करेंगे इंशाल्लाह, दिलों को इत्मीनान पहुंचाएंगे अल्लाह के जिक्र से भी, लेकिन डायबिटीज को भी काबू करना बहुत ही जरूरी हो गया है.
So, in response to Professor Salma Kundi, I can offer, whenever is convenient, another talk of pathophysiological, underpinning pathophysiological principles of diabetes mellitus. And,
That-
Sir, in the second week of the February, we
Inshallah.
are arranging a webinar. One person is from the USA, and you will be the panelist, inshallah, there. We'll pay on the pathophysiology because PAP and Physiological Society made this webinar as a pathophysiology.
That is
Okay, sir.
Professor,
Professor,
may I suggest that divide this topic into two. Number
Yes, sir.
one is the type 1 diabetes mellitus, and second is type 2 diabetes.
Inshallah, we are holding two topics, sir. Two webinars on it, and inshallah you will enjoy it. And you on the advice of Professor Salma Kundi, we have invited one of the professor from the United States of America, and along with Janasab. Okay, Janasab, I have one question before I ask allow other people to. You have mentioned 1, 2, 3, 4 brain, pituitary, heart, kidney, and the vascular. Your second last slide. Which is the most important factor in causing the hypertension, sir? Which is the most important among these all four?
Really can't say, but mainly is the cardiovascular and then is the kidney. Lekin, देखिए, all the systems in the body are generally controlled, regulated by the neuroendocrine system. दिमाग खराब है तो सब कुछ खराब है जिसमें. So controlled by neuroendocrine, but on the face, I would say cardiovascular and the kidneys.
Thank you so much. In my experience, sir, the most heart attack, myocardial infarctions are due to this brain you are telling.
Yes.
दिमाग खराब है ना, sir. But the most important, as a pathologist, as I observed the data, we have the data. The most important factor with the age is, and the diabetes is causing most effect
Yeah,
on
sure.
the vascular system, and then is the heart. Definitely, capillaries, and that is the arterioles, and the cardiac arteries are the part of this vascular. Pathology mostly lies, and then the kidney, and then other things. Very important thing. Professor Munir is there. Professor Munir, जी sir, what you, Jana साहब क्या कह रहे थे?
Thank you. Agreed.
Professor Munir, you are asking Professor Munir, Professor of Pathology. Professor Munir.
Thank you very much, Professor Mulazim Hussain Bukhari. It was an excellent presentation by Professor Mohammed.
सारा सबक याद हो गया.
Thank you, sir.
मेरे बहुत छोटे छोटे बेसिक से क्वेश्चन है और कुछ मैं आपके साथ शेयर करूंगा. एक तो ये बता दीजिए, हमारे पास मेडिसिन के प्रोफेसर भी बैठे हैं, कि ये जो इसको कंट्रोल करने के लिए ब्लड प्रेशर जो है वो वीकली बेसिस पे चेक करना चाहिए या डेली चेक करना चाहिए? क्योंकि मैंने देखा है जब मुझे शुरू में ब्लड प्रेशर हुआ था तो इस बात की वजह से ही काफी ब्लड प्रेशर रेज हो गया था। तो एक तो ये बता दे, दूसरा मैं आपसे शेयर करूंगा कि अल्लाह पाक को याद करना तो बहुत इम्पोर्टेंट है, लेकिन इसमें जो मॉर्निंग वॉक है या वॉक इन जनरल है, किसी भी वक्त हो, वो बहुत अच्छा रोल प्ले करती है। और जो दूसरा तीसरा सवाल मैंने पूछना था कि ये जो मेडिटेशन है, जो आप देखें योगा और इस तरह की चीजें जो एडवाइस करते हैं, इनका क्या रोल है? और ये जो आजकल जो हम अपना जड़ी बूटियों का लोग एडवाइस करते रहते हैं, इनका क्या रोल है?
Dr. Munir, you have a multiple question. Dr. Professor Aslam साहब, I will request very important topic. पहला सवाल तो क्या है कि डेली चेक करें या कब चेक करें? दूसरा सवाल मॉर्निंग वॉक का था, तीसरा सवाल इनका डाइट का था, चौथा मेडिटेशन और उसका था। जी
देखिए जी, सबसे पहली बात तो याद रखें, बिल्कुल आपकी बात सही है। मैंने सारा बताया कि all the functions of the body, including cardiovascular and renal system, they are controlled by neuroendocrine system. So पहली बात तो यही हो गई। दूसरी है कि हमने अभी तक इस टॉक में we have not taken care of the preventive, like medicine or promotive medicine. That is, this talk is lacking in preventive and promotive medicine. Of course, salt restriction करें, morning walk करें, positive सोच रखें, immune system बढ़ाएं. Obviously, it is going to affect the neurotransmitters and norepinephrine, epinephrine, and going to affect, dilate the arterioles. So can't be two different opinions. But कितनी दफा दिन में करें ना करें, because I have never been a practicing physician, so I feel handicapped in answering to your question कि जी किस पेशेंट को कितनी बार करना चाहिए, नॉर्मल बंदे को कितना करना चाहिए, ओल्ड पीपल में आफ्टर 60 years of age कितनी दफा करना चाहिए. So better, I think the practicing clinician will be more qualified to answer this question.
Thank you, Professor Munir. आप तो माशाल्लाह, now you are about 27 year age and you can have a regular walk. Professor Ahmad, Dr. Ahmad Murtaza. Dr. Ahmad Murtaza, you have raised the question.
Yeah, Assalamu alaikum, sir. First of all, it's an honor and
Sir,
pleasure
आप
to
अपना
listen
तारुफ
to
करा
you.
दें जरा.
Sir, I'm associate professor in physiology and a student of sir as well, and Madam Shanaz Javed Khan. And sir was my examiner in physiology in 1996 in King Edward.
We share the same mentor.
Yes, sir. I am working, sir, as associate professor in physiology, CMS Kharia Medical College, sir. Sir, it was a very elaborative and easy and palatable talk. Thank you for that. And I just want to comment on that, but you already have started that debate regarding the preventive measures, because pre-hypertension and diabetes, those individuals, they have a sort of a constellation of metabolic syndrome, which comprises hypertension and diabetes as well. So we need to raise awareness for screening programs in our community to identify those individuals at an earlier stage. As you have said, mentioned pre-hypertension, it is important because all these micro and macrovascular complications are initiated, and in pre-diabetes especially. So Ma'am Kunti has also raised a very good point that we should focus on preventive measures, and it's important if you can just educate us about the pathophysiology, because Pakistan, India, and Bangladesh are in the top 10, sir. So based on my mere experience as a clinician in Norway, I do my locums there, it is advisable that 24-hour blood pressure monitoring should be done, but it might be done in big cities in Pakistan, but in the periphery, I think that is lacking. The 24-hour blood pressure monitoring gives a better sort of overview of the patient recording, and then try to elucidate that the risk or stress factor among patients, whether he is labeled as a hypertensive or not, sir. Thank you again, sir. Sir, it was an honor to hear from you. Sir, it was all my humble suggestion. I am your student, and it was really great to see you after a long time. May Allah bless you with good health, and
thank you very much.
And keep on teaching us, sir. Thank you.
Oh, thank you very much. God bless you. God bless you.
Professor Rashid, इससे पहले कि मैं आप पेशावर वालों को दावत दूं, बलूचिस्तान से कोई ठंडी ठंडी हवा आ रही है. प्रोफेसर सरवर.
Assalamu alaikum, sir.
Walaikum assalam wa rahmatullah.
I'm in a visiting some tourist resort here in Dadar.
MashaAllah.
And I'm participating in your program.
Thank you. God bless you.
This is the end of Bolan Pass.
It
is Bolan Pass end.
Great, great. Salute.
Thank you, sir.
Okay. Okay, Professor Rashid Saab. Professor Rashid Saab.
Please
Professor Rashid,
switch on your
Professor
mic.
Unmute करें, unmute करें, ask करें जी, Professor Rashid Saab.
तो सर साहब बहुत अच्छी प्रेजेंटेशन पैथोलॉजी फिजियोलॉजी फार्माकोलॉजी कंबाइन कर दी। मैंने रेज किया था, एक क्वेश्चन आया था बीपी चेक करने के बारे में, चूंकि मैं प्रैक्टिसिंग हूँ और ब्लड प्रेशर पे कुछ कोर्सेज भी किए हैं। ब्लड प्रेशर चेक करने के लिए तो आप डेली दूसरे तीसरे चेक कर सकते हैं। जो रिकमेंडेशन है लेटेस्ट, जो यूरोपियन गाइडलाइंस है 22 की, वो ये है कि आप अगर इमरजेंसी ना हो तो 2 हफ्ते तक मेडिसिन चेंज ना करें। यू टाइट्रेट दी मेडिसिन एवरी 2 वीक्स। अगर 2 वीक तक एवरेज ब्लड प्रेशर कंट्रोल नहीं होता, बेस्ट इज द एवरेज रीडिंग इन द लास्ट 14 डेज। तो अगर बीपी ज्यादा है तो ऐसा से ज्यादा करें, अगर बीपी कम है तो उसको ऐसा से कम करें। और बाकी चीजों के जवाब असलम साहब ने दे दिए थे, इसमें कोई शक नहीं है। अल्लाह का जिक्र भी जरूरी है, डाइट भी जरूरी है, और मेडिटेशन भी इबादत ही है, वो भी जरूरी है। और वॉक का और लाइफस्टाइल का बहुत इंपॉर्टेंट रोल है। आप वॉक करते करते भी जिक्र कर सकते हैं, और जिक्र से मुराद सिर्फ अल्लाह अल्लाह नहीं है, इसमें फ्राइज भी शामिल है, इसमें नमाज भी शामिल है, रोजा भी शामिल है, और तमाम जो सुबहान अल्लाह अल्हम्दुलिल्लाह जो चीजें सब शामिल है। तो ये वो क्लिनिकल जो क्वेश्चन पूछा गया था, तो मैंने प्रैक्टिस के हवाले से जवाब दिया। इट इज मेडिसिन इज चेंज एवरी 2 वीक्स, और फिर गाइडलाइंस है। फर्स्ट है इस पे angiotensin receptor blockers हैं, then you add a diuretic, then you add a calcium channel and so on। एक बकायदा गाइडलाइंस मौजूद है उनकी वेबसाइट पे। थैंक यू वेरी मच।
Sure.
Thank you. If there is no question, I will ask
Professor Mulazam
to conclude. Yes.
Professor Mulazam, may I say something?
जी sir.
If you allow me, Professor Aslam must be knowing Professor Steve Allen from England. He is willing to participate as a guest speaker on the type 2 diabetes mellitus. And if you say and you
contact number दे दे, मैं उसको जी contact number दे दें सर।
yeah, I will send you the email address.
मुझे मैसेज कर, मेरा नंबर आपके पास है, मैं उससे जी उससे बल्कि कमिटमेंट भी ले लें।
Okay, I will send you his email address.
हमारा जो अगला प्रोग्राम है ना, वो आर्टिफिशियल इंटेलिजेंस पे है। जो अगला प्रोग्राम है हमारा आर्टिफिशियल इंटेलिजेंस पे, यूएसए के प्रोफेसर, और उससे जो अगला हमारा वीक है उस पे हमारी कमिटमेंट है कि ये सर्वाइकल कैंसर का मंथ जा रहा है, सेलिब्रेट कर रहे हैं, तो गायनी का है। और उसके बाद एक हमारी फिजियोलॉजी की प्रोफेसर है, वो हमें बताएंगी कि असेसमेंट कैसे करते हैं। और उसके बाद डायबिटीज है। ये 4, 5, 6, 7, 8 हमारे ऑलरेडी बुक्ड हैं, क्योंकि हमारा जो प्रोग्राम है अवेयरनेस का इतना बेहतर है कि हमें वो चार्ट बना देते हैं कि उसके साथ। इनके बाद I will request all teachers, but the teachers that Azad Jammu Kashmir Medical College, Muzaffarabad, with collaboration of UHS and America, we have started a 3-month program on the research. And if any of the students, any person interested, because there are the pearls of the teachers who do the exercise workshops and lectures on for this certificate program, and the certificate will be issued through the UHS with the name of Azad Jammu Kashmir Medical College, Muzaffarabad. So before this I conclude, I will request Professor Salma Kundi, who is the always host of this program, to conclude today's program.
Thank you, Professor Mulazam Saab. I'm really indebted to General Dr. Muhammad Aslam Saab, who's a legend in our physiological circles. Stay blessed, sir. It was such a beautiful talk. And thank you so much, Mulazam Saab, for always being there for arranging this wonderful series of webinars. I thank all the participants over here on behalf of PMA, Women Medical College, Azad Jammu Kashmir Medical College, Society of Pathologists, our Physiological Society, and South Asian Physiological Society. Thank you so much. Let's continue this great series of webinars. We've already conducted 59 and the next will be our 60th webinar. And inshallah, hope to meet every week. We had a good turnout today as well, General Saab. The only flaw was it was Sunday and really the prayer time and lunch time. So I think 11 o'clock is better for everyone. We should continue it at 11. That is it. Thank you so very much. Stay blessed. Have a good Sunday. Allah Hafiz.
I appreciate the
फौज वालों का
effort
असर होता है,
of-
फौज वालों का असर होता है कि वो वक्त तब्दील कर देते हैं, तो
I
जाहिर है
appreciate
I apologize,
I
but
appreciate
क्योंकि
this.
आज हमारी AMC की veterans का 3 साल के बाद, COVID के बाद 3 साल के बाद उनका get together था. So I apologize to change the time.
नहीं सर, it's okay.
I appreciate the effort of Professor Mulazim San to make a separate group for the webinar. This is the result of this effort that we have put attendance in this webinar. Thank you very much, Professor Mulazim San, for this.
Thank you, Chief.
Thank you very much.
Thank
God bless you.
To everyone.
बहुत
Wish you
शुक्रिया.
good luck,
Thank you
everybody.
very much indeed. Allah Hafiz.
Assalamu alaikum.
Wa alaikum assalam wa rahmatullah.